You're listening to The Q Switch with your host, Spence.
Welcome, one and all, to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we attract the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right on in. The title of today's episode is Vision by Addition, and we're joined by a surgeon whose career reads like a highlight reel of excellence and impact. Born in Erie, raised in Augusta, and now making waves in North Carolina, we have Dr. Sheel Patel, who has stitched together an impressive journey from a combined bachelor's, and medical degree program at Kent State and Northeast Ohio Medical University to chief residency at UNC Chapel Hill to fellowship training at the world-renowned Wilmer Eye Institute at Johns Hopkins. He's a corneal refractive surgeon specialist, a partner at Cape Fear Eye Associates in Fayetteville, North Carolina, a dedicated educator at Campbell University and Drexel University, and lest we forget, he hails from Western Pennsylvania, so he is an unwavering Pittsburgh Steelers fan. Today, we're diving into one of the most exciting developments in corneal surgery today, CTAK, corneal tissue addition keratoplasty. And Dr. Patel is here to talk about it and illustrate it with two compelling case studies and that truly show what this procedure can mean for patients. Dr. Patel, really been looking forward to this episode. It's great to have you here. Welcome to the show.
Much appreciated, Spence. I appreciate that introduction and excited about this technology and getting a chance to talk to you about it.
So you've had a remarkable education and training pathway from UNC to Wilmer Eye Institute. So looking back, what was the pivotal moment that shaped your decision to specialize in cornea and refractive surgery?
But when you're a resident and everything's flying at you, you're just trying to do your part, make sure you keep up with what your residents, your upper levels expect of you, what your attendings expect of you. So that's really your first year. When I moved from my second to third year, it really allowed me to think about what part of ophthalmology I want to specialize in. And I had a couple of attendings that really helped me think about cornea and move in that direction, improving people's quality of life, really being super precise with corneal treatments. I was down the alley that I was looking for, and that informed me to go into.
Well, you certainly have a great track record and a great history that's very compelling for most folks to learn. Your bio talks about the gratification of restoring vision. Can you share a moment early in your career when you realized ophthalmology was the perfect fit for you?
So I followed up with a primary care doctor who taught me a lot about medicine and life in general, and I had a chance to follow a lot of different specialties. I saw many neat things in various subspecialties, but the day I saw my first cataract surgery, seeing it directly as well as on the screen, I knew that was what I wanted to do. The precision, the accuracy, seeing what the surgeon was doing and how the patient handled it, I knew what I wanted to do. So that kind of informed me of my future, and I followed every path I could to try to get into ophthalmology after that. So I was lucky to really see that, be in that setting at that time so that I had time to move in that direction.
Well, cool, man. Well, thanks for sharing that. Well, before we get into the science, let's get something out of the way right now. I, too, am a lifelong Steeler fan, probably for a completely different set of reasons. But I got to ask how you feel about the black and gold this season.
I'm diehard. So, I've watched games from when I was 3. So, there's a lot of noise up and down. You can't be fair weather when you're a Steeler fan. I'm all in, and I'm an optimist, so that helps me stay locked in. But if I wasn't, I'd probably be thinking about some of the things that you're hearing at the stadium and elsewhere. But I'm locked in.
Well, good. So am I.
Good.
Hopefully, good luck the rest of the way, I guess.
Yeah, definitely.
So for those hearing about it for the first time, what exactly is CTAK, corneal tissue addition keratoplasty, and what clinical problem is it designed to solve?
Certainly. So corneal tissue addition keratoplasty is a way to add donated cornea to a patient's eye that has keratoconus. So historically, when you have advanced keratoconus, a penetrating keratoplasty or full thickness corneal transplant is performed. And I've done many of those over the years, but it is a significant surgery, healing period, and it entails a number of other issues, potential risk, issues with healing, and long-term outcomes in terms of potentially needing specialty contact lenses. So there's a lot of layers to it. And because of the risk and kind of life-changing aspect of penetrating keratoplasty, I have a number of visits with the patient before I know that they're in for the whole treatment course. Having CTAK, or corneal tissue additional keratoplasty, what it allows us to do is add tissue to a patient's cornea without taking any tissue out. So in keratoconus, we have an irregular cornea. And when you think of astigmatism being more like a football shape of a cornea than a basketball shape on a microscopic level, since we're talking about football, I would talk about a keratoconic eye being like a warped football. So it's maybe a little rounder on one end, a little pointed on the other, so that when light rays hit an eye that has significant irregular astigmatism, it's not going to bend equally. It's going to bend steeply in some parts of the cornea, not as steeply in others. So it creates a lot of distortion because the light rays are not meeting at a certain point. By putting tissue in the thinner parts of the cornea and typically the steeper parts of the cornea, it helps flatten the cornea and makes an irregular cornea a lot less irregular. I can't say that makes it regular, but it makes it a lot less irregular, so that patients have a lot greater functional vision afterwards and not as dependent on having a specialty fit contact lens, although those will help their vision after this treatment, but they won't be as dependent on a lens like that. And they may have the potential for vision with glasses when they might not have been able to beforehand.
And how does CTAK differ from traditional approaches such as corneal cross-linking, Intacs, DALK, or PK for patients with keratoconus or corneal thinning disorders?
Certainly. So I feel like it goes hand in hand with corneal cross-linking. Corneal cross-linking has been a game changer in our field as well. I think both of these treatments have been fantastic for keratoconus. And cross-linking, we take off the epithelium or top layer of the cornea and for epithelium off corneal cross-linking, and then use riboflavin drops followed by UV light to strengthen the cornea. So that helps with the integrity of the cornea so that it resists change going forward. So historically, since 2016, we had FDA approval for epithelium off corneal cross-linking, and we've been doing that. And we've been able to keep people from a full thickness transplants by doing that procedure. Now, most of those patients don't get improved vision afterwards. We do feel great that they're not going to typically worsen, or their speed of progression or worsening is much slower, but their acuity still becomes an issue because a lot of these patients are either legally blind or significantly visually impaired. CTAK, now, it changes the corneal shape pretty dramatically. It flattens the cornea and makes it a lot less irregular. So patients' vision, their uncorrected vision, in studies by Dr. Peter Hirsch, Dr. Greenstein, and Dr. Gellies, showed there's about 6 lines of uncorrected visual acuity improvement and about 3 lines of best corrected visual acuity improvement. And that's along the lines of what I've seen, and some patients significantly greater than that. So it allows functionality and ability to drive and work, some things that we take for granted. But these keratoconic patients, when they're moderate to severe, they cannot do these things, or if they're doing it, they probably shouldn't be.
So it sounds like it's all about the visual outcome. Integrity of your cornea is fine; it's going to stay in place. We did the cross-linking, but their vision doesn't improve. Their quality of life is still less than what it could be. So when CTAK comes into play, now you take it to the next level. Not only are they from a integrity standpoint, now they can actually use their vision. Is that right?
That is exactly right. So, that's part of the mission for all of us in ophthalmology, and whether you're a cornea specialist or at various subspecialties in ophthalmology, our mission is to improve quality of lives, whether it's by how their eye feels or how they're seeing, or a combination of those factors. So this has really been a game changer to help improve quality of vision.
Well, so
function.
it sounds like cross-linking and CTAK really kind of go together to really be that perfect prescription for a patient with some of those corneal thinning issues and keratoconus.
Exactly. Not all eyes need both of them, but moderate to severe, I usually do a combination. And now with epithelium on cross-linking being FDA approved just recently, that will be used in conjunction with CTAK. And going back to your question earlier about Intacs, I've done Intacs over the years with great success. But after I did my first CTAK, I realized that CTAK's what I'm going to be doing going forward, because it just takes it to another level in terms of what we're seeing with outcomes and what the FDA studies are exactly what we're seeing in practice.
It kind of leads me to my next question. So where do you see CTAK fitting in the current treatment algorithm? Is it an early intervention, a bridge, or a last line option? I mean, you were kind of speaking to it there, but I'm just going to expand on that.
If epithelium on cross-linking was our only option for cross-linking, then I would do CTAK first to help visual acuity gains.
First?
Yeah. Seeing the initial outcomes from CTAK has created a paradigm shift in how I treat keratoconus now. So I want them to function better, see better, drive better initially, and then we can work on the integrity of the cornea for long-term benefits, because many of these patients may continue to drive when they shouldn't be, or they will never drive and depend on others to do that. So I've switched the order in which I do it because of what the results are showing. Epithelium on cross-linking may give us the opportunity to still continue doing cross-linking first, because the healing period is smoother, quicker, and less uncomfortable.
Okay. So let's turn to the surgical process and the workflow. Walk us through your CTAK surgical workflow. What does the planning, tissue selection, and intraoperative process look like from your perspective?
Certainly. The planning is very neat because this is a customized process. And
Customized.
I have a great team with Cornea Gen, Jason Brill, Mitch O'Donnell, and Stephen Murray. They help me out. When I get a patient who could benefit from CTAK, we take their Pentacam scans, get it uploaded. The planning goes into place. It's almost some engineering on the cornea to determine what the incision site will be on the cornea for the laser tunnel. And then we determine the arc length of tissue to be used along with the thickness of that tissue graft. And when we see a map that gets sent over to me, I look at it, and typically we're on the same page or talk about ways to slightly modify it if we feel like that would benefit the patient. And then we order the tissue. I started these cases in late April of this year. And at that point, it was taking about 5 to 6 weeks to get the tissue made. And it's because it's customized and it's a process. And hearing about the quality control involved with what Cornea Gen is doing, there's good reason for that time. Now that more and more cases are starting to be performed, they've gotten that down to close to 3 weeks. So now we can get to treatment earlier, and this is customized. So we take that plan, we order the tissue, and then we get to the day in the OR. I do this at a hospital outpatient surgical facility, and we take the patient into the laser room. We have their eye marked for centration, lay them down in the laser room, and create a tunnel based on the incision site and the inner and outer diameter of the laser tunnel. Patient then goes into the operating room. We open that tunnel and very meticulously open the stromal fibers in the cornea so that this tissue can slide in smoothly, because unlike Intacs, which is a more rigid material that can almost open a tunnel on its own while we push it in, this tissue is wider and donated cornea. So it is softer and requires that opening of the tunnel to allow it to slide in like we want it to. And we match it up to the plan that we have in place, put a contact lens on the eye for comfort that first 24 hours, and then basically use their antibiotic and steroid drops until they follow up the next day.
Well, thanks a lot for taking us through that kind of journey through the procedure and what the patient would experience. Along the way, you'd mentioned a couple of things, equipment and so on. So what specialized technology or equipment is required for surgeons who want to adopt CTAK? Anything beyond what a typical cornea practice already has?
So the typical things, a Pentacam or other corneal tomographer. And once we get the plan in place, what took probably the longest time was coordinating the hospital outpatient department to get the laser to have the appropriate software for CTAK, because most of those lasers that are in an ambulatory surgery center or hospital outpatient department are geared toward software for laser-assisted cataract surgery. So we worked with Alcon in this sense because we have a LensX laser. They helped with getting that adjusted for CTAK utilization. and then getting all the approvals from the hospital to do this new procedure. So that took some time, but I was ready to start working on this the moment I heard it was approved, because the results that I saw a few years ago at ASCRS made me very interested. And I followed up on that until the moment I heard it was approved. So I basically told them, we're going to get this going. And seeing those first few cases really validated, what we were seeing in studies and the results.
So totally have a question I want to ask you that's almost related to that before I forget. Let me jump to this first question. It is in terms of, I know you obviously early adopter, and embraced it even before it came out, was FDA approved, and you learned quickly because obviously you're motivated and very smart and all this stuff, and it's nothing outside what you normally do. Just make a few adjustments and learn the technique and all. But what is the learning curve for, just generally speaking? Are there any things that might be hiccups or things that people may have trouble grasping in terms of adopting this technology? Are there specific skills or refractive or corneal surgery backgrounds that make this transition smoother?
Sure. If you're a corneal surgeon or an ophthalmologist who takes care of keratoconus historically and have performed intacs, then it makes the learning curve a lot flatter and smoother. You have the skill set to place tissue in a partial thickness fashion in the cornea in ways that makes CTAK a lot smoother. Now, there are some nuances that will come along the way as you learn it, but CorneaGen has a great process to help you along the way to support you. But it's definitely well within the skill set of corneal specialists or those that have taken care of keratoconus, particularly with the intacs background and experience.
In our pre-call, I believe you shared, and I think you just shared a moment ago, that you performed your first CTAK case in April, I think. And assuming you've performed many more since then, generally speaking, what outcomes are you seeing in terms of visual acuity, corneal stability, and patient satisfaction?
We've performed about 30 cases now, 30 eyes, and I'll tell you, it's just been shockingly good to where, like I told you, I'm an optimist, a realist, but an optimist. But when I see some of the visions written in the chart that our techs have put down, I've somewhat doubted that someone can see that well when they were count fingers or legally blind. So I've rechecked a number of these patients and have just been dumbfounded by the results. So the team, like I mentioned, Dr. Hirsch, Dr. Greenstein, Dr. Gelly, they're the ones to really get all the credit for what they've done to get this phenomenal procedure going. We're basically the surgical ambassadors for this procedure. The point of all this is we need more corneal specialists or ophthalmologists or taking care of keratoconus doing this procedure, because they will not turn back. It's been pretty amazing.
Well, as I was preparing for the show, I was trying to see, who actually is doing this procedure, and there's still a relatively low amount, which is why, of course, I wanted you to have me on the show to kind of promote it and, share that this is available and kind of talk about it. But I'm here in Miami, so I've asked a couple of the doctors at Bascom Palmer. They said, yeah, we do it. And it's, like you said, it's amazing. It's a game changer, all those type of adjectives. I was looking at some YouTube videos. There's a couple of doctors in Philly. What's his name?
Dr. Ayers, Brendan Ayers.
Yeah. Brendan Ayers. Yeah, he has a great video on it. And I think the case he has on YouTube was his very first case. Yeah, so yeah, it's starting to get out. And as successful as this is, it seems like it's less invasive than some of the other options. And how long does the procedure take, by the way, once they've been taken back to, say, the laser room to start?
So in the laser room, it may be about 5 minutes. A lot of it's just marking and positioning, getting the patient comfortable and doing that part of it, and then getting into the OR. It can take 10 to 15 minutes over there. I'd say more than actually the procedure, getting that tissue is clear and it's in this albumin and solution. And one of the things that we talk about is sometimes it's more complex trying to fish this out of that albumin and find it. And because it takes a tech and the surgeon to find this and not, lose this very valuable piece of tissue that's been donated. So we very meticulous with slowly filtering that fluid out so that we can get the graft, clean it, gradually open that tunnel, and then place it. So it could be 10 to 15 minutes in the operating room, along with some time in the laser room.
Any potential setbacks or any risk factors that may play into the procedure? It sounds like it's pretty low level and pretty low risks. I mean, what are your thoughts on that?
Yeah, when you're placing tissue partial thickness into the cornea, you always are thinking about the low but possible risk of corneal perforation. That has been essentially all but eliminated by using a laser to create that tunnel instead of it being self-guided and using a blade. So that essentially eliminates that. We're trying to avoid infection, and we've been, fortunate with following the protocols that we all use for sterile technique and antibiotic drops and meticulous cleaning the lids prior to surgery. So all those things really help avoid those issues. Dry eye is prevalent and going to happen with any corneal surgery. So we inform the patient we're going to really treat that dry eye aggressively before and afterwards so that they can have an efficient healing course.
And how soon do the eyes respond and patients notice improvement? And how does the recovery compare to more traditional grafting or ring segment procedures?
Sure. We're seeing from day one, people are moving from outside the Snellen chart of count fingers to where, like I was saying, I'm rechecking vision because there's some of these patients. I've had some patients 20/40, 20/50, day
What?
one day one after the contact lens removed. So we're just rechecking some things. I'm not saying that's everyone. We have some people that are 20/80, 2100, but they're going from their best correction with glasses, not better than, count fingers or 2400, to where they're seeing that without any correction. And now their cornea is flatter, so their prescription will change, and then they have potential for much better afterwards. So they can get it as early as day one. Now, people will be more light sensitive the initial few days. So everyone's different in terms of how they can process that and see through that, in a sense, day one and 1 week. But some patients will take a week or a few weeks to get more consistently better. But day one is where we're seeing a fair number of people tremendously better.
And what are the patients' reactions when they see for the first time, 6 lines of improvement on their vision check?
Yeah, I mean, a lot of them are shocked, and then some people are just kind of shocked how shocked I am seeing how great they're seeing. So we're all happy.
And I know, like with cataract surgery and lens selection, it's very there are patient profiles that align better with certain technologies. Are there particular patient profiles with CTAK that seem to deliver especially meaningful benefits?
Yeah, certainly. We'd love to do this on all keratoconic patients, but you want to have someone who has this clear visual axis. So if their keratoconus is so severe that they've already developed central scarring in their visual axis, then they're most likely going to go along the lines of a penetrating keratoplasty or the full thickness transplant. The other things are you need to have at least 300 microns of corneal thickness in the proposed laser tunnel area. So it has to be thick enough. Now, I did treat my initial patients. They were moving into a level where they would otherwise need a transplant. So I had a couple that were even more severe than what they proposed, and they still did very well too. But we're not going to treat patients that have a significant central scar or corneas that are too thin to create an adequate laser tunnel. But otherwise, they're usually in the moderate to severe keratoconus. They're mild to moderate they can get benefit at that level too if their vision is limited.
Now, how about the rate of rejection? I know that with full thickness cornea transplants, there's a potential of a rejection. Is that even a possibility with this CTAK procedure?
Great thing is theoretically, no, they should not have any risk of rejection because the tissue gets gamma irradiated. So that gamma radiation, it goes through the full thickness of the cornea. So it provides a little bit more rigidity to the cornea than the typical donated cornea. And compared to like E-beam radiation, it penetrates deeper so that your risk of rejection is all but eliminated. So we're not putting patients on long-term steroids with this. It's just your first couple weeks or, whatever each doc's regimen is. But you don't need to do the extended year or many years of steroids like you would with a transplant.
More good news there.
Yeah,
for the patient, because I know that compliance over a long period of time is extremely difficult, and you rely on the patient to handle those things. I don't care what the drop is. It's just one of those factors that, once they leave the office, you can't control it, and it can really go south quickly, especially something like this.
Yeah.
So instead of just talking about CTAK, I thought it would be more effective for you to show our audience and feature a couple of case studies. Can you walk us through the first one? And what was the diagnosis? What led to you selecting CTAK? And what was the post-operative outcome?
This first case is a very interesting one. It's the mom of a mother-son duo that I treated over the last 6 months. And she had a best corrected vision of count fingers at 5 feet in each eye. And for her, she had severe distortion in her vision with or without glasses. And unfortunately, due to finances and insurance issues, she was not able to obtain a scleral lens or specialty contact lens. So she has just been impaired and not able to drive or function. So we treated both of her eyes. We started with her right eye, and then we did her left a few weeks later. At 1 week, she was 20/50 uncorrected in her right eye and 20/40 in her left eye. And
What?
yeah, it, and it was one of those that I had to recheck the vision a number of times. She was she was in tears. I was shocked,
Yeah.
and we were just in awe of how her healing's gone, and now that she can basically drive before we even changed her glasses, and now she's not dependent on getting a specialty lens that she couldn't afford beforehand. We could potentially get her now into glasses to function at even a higher level than she was at. So that was so remarkable that her son, as we know, this has a genetic link. He came in a couple months later and treated him. He's a big boy, like a football player, and he came in and he's like, I heard about what happened, and he came in and we got him taken care of. Fortunately, his eyes were not as advanced because he had it done earlier, but had a fantastic result. I want to go to the pedicam of that first patient I was talking about. And so she had her corneas were in the moderate range of corneal steepening. They weren't dramatically steep, but the central corneal steepness was in the mid 50s. And we were able to flatten them postoperatively to where it came down 3 to 5 diopters. And even though that was not a dramatic difference, it created a dramatic shift in the shape of her cornea to where that uncorrected vision improved significantly. So her prescription has dropped at a significant rate. And now her glasses prescription will be thinner, create less distortion, and she won't be dependent on getting those specialty lenses.
And you were saying with that particular patient, she counting fingers at 5 feet on both eyes. And you pretty much like gave her life back. I mean, her independence, being able to go anywhere she wants safely, just really function as if her vision was much, much better. And you gave that back to her, man. You said she had tears. I would too, man. You probably get a lot of that, I'd imagine.
Yeah, we like happy tears. So, you know, for her, the fact that she can now have driving as an option was awesome.
So you do have a second case. So tell us about that second case and any unique challenges or standout results that highlight the value of this technique.
So the second patient is a young lady as well. And I initially saw her in 2023, and we talked about corneal cross-linking. And corneal cross-linking is amazing and a game changer, like I'd mentioned, but it takes a week of downtime because we're, taking the epithelium off. So patients have to buy into that week off, and it's going to be sore and uncomfortable initially. So we had that discussion, and like many corneal specialists will realize a certain percentage of patients, you don't see them until they resurface a year, 2 years, 5 years later. And unfortunately, with keratoconus, it is worse when we see them back. So
yeah, they pay the cost of waiting, man.
Yep.
The cost
and
of waiting.
I saw her back 2 years later and looked at her pedicam, and internally, you got that sad feeling. It went downhill. So it pushed her to show back up. And the positive for her is now CTAK was available. In the past, we would be talking about the same thing. So we talked about insurance issues that were partly what kept her from proceeding before. And the other part was a little bit of fear of the process. But we wound up doing her case the first day, the late April, when I started these cases. So
she was your first case, this young lady.
Signed her
She was
up.
your first case.
Yeah, because in her right eye, she was 20/50, and in her left eye, she was count fingers at 3 feet. So we decided to get that left eye rolling right away. So we started with her left eye, and one day she was 20/80, and her 1 day post-op. awesome return of vision, although she had the healing course and initial light sensitivity. By 6 weeks, she had improved to the 20/40, 20/50 range, and this was before we even put her into glasses. So she was then motivated to get her other eye, which was a good bit milder, but she wanted to have that in her better eye so it did not turn into what her left eye had turned into. So she was very excited. Her corneal thickness, as you can see on the Pentacam, was on average 81 in the left eye preoperatively, which is corneal transplant level historically. But we decided to go for it with CTAK with good informed consent that if we didn't get what we wanted with this, we'd go down the path of a corneal transplant. But once we do a transplant and make that full thickness incision, the eye is structurally not as strong as it was before. So it would be worthwhile to give CTAK an opportunity. And it delivered. Her postoperative corneal steepness was 69 in that left eye. So she had 12 diopters of corneal flattening. So when we get a couple diopters of flattening, that's one thing. Over, double digit level corneal flattening is tremendous.
Wow. That is a great, I mean, if you're trying to sell this thing, that would do it.
Yeah. So that's the reason this translates into vision. And she was ready to get that other one done and just had a
one of the things
outcome.
that you mentioned was that if after someone gets a corneal transplant of any kind, that they're not eligible for CTAK. Is that correct?
Correct. Because where we make that cut to take out the central cornea for the host patient, we stitch it in the typical zone that the laser tunnel would need to be made. So that makes them essentially ineligible for CTAK.
Okay. Just want to clarify because you mentioned you told the patient X. I was like, oh, that's a probably a good question I should ask. I'm sure that somebody out there has that same question. To our audience, Dr. Patel shared these 2 cases. We're going to add another 3 cases, so it'll be 5 total to this episode, so you can check those out and look at those pentacams and other information. And we'll provide his information at the end of the show as well, so you can reach out and ask questions and have that conversation should you have any, okay? So with that, let me go on. From these 2 cases, what clinical lessons or pearls would you share with the surgeons evaluating whether CTAK is the right option for them?
Yeah, the CTAK gives us an option to intervene sooner and in a way that can help our patients function better on the earlier end. So if you've been treating keratoconus for a number of years, when you do a few procedures, it may change the way you approach it, paradigm shift, as I'd mentioned. And as long as they follow the criteria and don't have that central steepening, it gives us an opportunity to treat them before they progress to the level where we don't have that opportunity. So that is part of our discussion with these patients, that these treatments are not an emergency, but we have the option to do less invasive, partial thickness or more superficial treatments while we have the opportunity. And at some point, like a lot of things, the window can close. And we want to treat in the safest and least invasive manner as we can. And CTAK and corneal cross-linking give us those opportunities so that we can do less full thickness transplants. And I think all corneal transplant surgeons would agree that is a good thing.
Yes, I agree 100%. So, I think you spent a lot of time on kind of the surgical procedure and some of those things, case studies. Let's turn to more of the practical integration, economics, and access. So from a practice management standpoint, how does CTAK fit into the reimbursement landscape? And are you seeing any changes or areas of needing clarity?
One of the issues that we often run into in the past and is the ability to take care of some patients that have Medicaid or if they're uninsured. Fortunately, Glaukos with corneal cross-linking helped us out with taking care of patients who are either indigent or are relatively underinsured to help out in that way. But in terms of improving visual acuity, it was difficult to do that as specialty lenses were not covered. CTAK is in the spectrum of a lamellar keratoplasty, like partial thickness transplantation in a sense. So having the ability to treat our patients who have Medicaid or other insurances that often don't give them the opportunity to have a procedure that was gratifying for me to be able to offer that to patients. Now, in terms of billing and coverage, it at least allows us to get some reimbursement for a procedure and make it a win-win in a sense, but most importantly, allow those patients to have access to these groundbreaking treatments and not feel like they have a second tier level of procedure. So for me personally, that was a great boon.
From surgeons considering adding CTAK, should they understand about the cost of entry, from equipment to training to ongoing tissue expenses?
Yeah, so you can actually create the laser tunnel in your office, and we have a laser that is compatible with that. But currently, the procedure is covered if you do it in an outpatient facility. So it would have been logistically an issue if we did a laser in our office and then transfer the patient to an outpatient facility. So we just do it all at Highsmith Rainey, which is our local hospital outpatient surgical center. And they would need a laser that is compatible with CTAK and having the software for treatment. So as long as they have that software on their laser, they will be able to perform CTAK on that patient with laser and in the operating room for the actual placement of tissue.
And you mentioned the software package for CTAK, and you use an Alcon platform for your laser, but obviously there's 2, 3, 4 different other platforms. Do they all have some form of software package to accommodate this procedure?
I believe most do. I know Zemer does because they actually do a lot of the cutting of the tissue to create the graft. There are several others, but I'm not fully certain which ones are compatible. But I know with ours, the LensX, it is. And usually the facility that houses the laser will take care of that, as you're going to be bringing those procedures to that facility. And the other part of it, we've been talking about expense on the front end. You need to get the equipment and specialized inserting devices as well as channel dissectors. So that has a decent amount of expense. You're going to be the person who's going to be doing a number of these treatments to make it cost effective for the facility that you're operating at.
And in terms of training, obviously this is still a relatively new procedure. What kind of training did you go through? And is there like formalized training or just like a certificate online? What does that look like?
For me, because I had been performing intacs before, it was more of a online sort of thing. But if you have not performed intacs or comparable procedures, then there would be more of a kind of wet lab where you're working with the trainer.
Okay. And this is offered by what company? The
Cornea
procedure?
Gen.
So Cornea Gen supports it in terms of the training and kind of just getting doctors kind of a startup kit, so to speak.
Correct. They will be, and they'll be there for your initial cases or as much as you would like them to be there.
Okay. So do you see CTAK becoming broadly accessible across diverse practice settings, or will it remain a subspecialty driven technique for a while? And what I mean by that is like MIGS, when that first came out back in 2013 or whatever it was just glaucoma guys. Not everybody and their mother. You got refractive guys who are straight refractive doing MIGS. So is this something that can expand out and become more broadly accepted by the greater ophthalmology community, or kind of really specialize in the cornea space?
Good question. I think you'll start more in the cornea space. I think comprehensive docs who take care of a lot of keratoconus, because there's certain areas, if you're not in a big metropolitan and you're that person who takes care of the keratoconus locally, and you're well accustomed to analyzing these pennicams and knowing the criteria for doing various procedures, then it should be well within their skill set and expertise to perform the procedure. I think it's all based on experience and comfort with treating those patients and being able to analyze the tomography to decide what's in that patient's best interest, because it's not like a cookie cutter or sort of process. You really want to look at the whole landscape of what's going on, patient's age, the progression, the thickness, scarring, and then you make that decision which one or two modalities you're going to utilize to help this patient the best.
And for a surgeon listening to today's show who's maybe on the fence, what would be your message about the procedure's value and future potential in cornea care?
Yeah, I'd say, the surgeons that I've seen utilize CTAK, and it's not a large number currently, but we're hoping and I'm anticipating it will be, because the results I'm seeing, the next CTAK surgeon is seeing, and so are the others. We're all seeing it. The procedure is brilliant. Innovators are brilliant to get this going, and doing your first day or days of cases will make you a CTAK believer and become bullish on using it. It's become my favorite thing to do, because we're seeing it's because what translates to great outcomes and great vision is what drives us.
So you now call Fayetteville and Cape Fear Eye Associates your home. How long you been in the practice?
Since 2006, almost 20 years.
So you are like in the community. Your practice really does hold a special place in Fayetteville. And so Cape Fear Eye Associates has deep roots there, and again, integrated into community, been there for at least 20 years. I'm not sure how long it predates your arrival, but can you talk about the practice's connection to the region and the kinds of outreach or charity initiatives you guys support?
Yeah, certainly. That's a big part of our practice. We've stayed locked in on helping our community, the community that trusts us. So we give back. My partner and I at the practice, Dr. Wayne Riggins, he's always been a big contributor and charitable individual, and I've definitely followed that lead and been alongside over the years to make that a continued mission for our practice and how we're viewed. The Vision Resource Center is an inspiring group. They help visually impaired and blind children and adults in their day-to-day life. They help them in societal ways. They help them acclimate to the community and help them become more independent in their lives. It's along the lines of what we do day to day, and we've had a great synergy with that group and have helped them along the way. They have a very neat yearly event called Dining in the Dark. So we've sponsored that over the years. And basically, you're sitting at a nice dinner. We all put on a blindfold, and to think about taking a sip of your water or drink and cutting something with fork and knife with a blindfold really gives you perspective on how difficult it is for blind or visually impaired individuals. So it gives us all a brief glimpse into what these individuals are dealing with and how resilient they are to live day to day. So that's one thing we do yearly, but we bought a van a few years ago to help a lot of children and adults get to their appointments or social events to, bring a little more happiness to their lives and help those that are on the board carry out that mission.
Thanks for sharing. And those folks in Fayetteville are lucky to have you.
Thank you. It's a heartwarming one, and they deserve everything. And it's great to see that group grow over the years.
So how has serving the community of Fayetteville kind of shaped your philosophy as a clinician and surgeon?
Yeah, Fayetteville is, a military town, and,
okay, I didn't know that.
Yeah. So, biggest military base in the country. And there's, over the years, there's the biggest realignment. And so, it's an area where you really appreciate the stories of the military, not just everything that we all are proud of the military for, how they protect us, serve, and do many things that we're not aware of. But to hear stories from friends, colleagues, and others really gives you a deeper appreciation at the greatest level of, what they do for us as a country. And, that's helped me initially having a greater appreciation and love for the community. And Fayetteville on the other end, we have a lot of pathology. We're not an elective practice. What we do day to day is taking care of patients who are either losing vision, going blind, less controlled diabetic or glaucoma issues and such. In the midst of that, yes, we do LASIK, we do cataract surgery, we do premium procedures, but it's all mixed, and it makes it a challenge. But those that we bring into our practice, they're in for the challenge. We have some awesome providers, and they have grit, and we're here for not just the fancy stuff. We're here for the majority of it is the not so fancy. And that's what we're here for. So our team is rock solid.
What's one piece of advice you'd offer your colleagues who want to be early adopters and follow your lead of promising surgical innovations like CTAK?
Yeah, I'd say, trust your instincts, trust that, we have the FDA. The FDA is rigorous, sometimes even more rigorous than all of us want it to be, but we hear what's going on overseas. And when we have opportunities to help patients, you can follow your nose and have all the medical guidelines to protect you, and talk to your colleagues to get their thoughts on it. But there's no need to wait on certain procedures. If you feel like you're going to be able to help patients at the next level, you can go for it. And it's good to have support of colleagues at your practice or ones that you speak to on a regular basis. That helps us. We're always in communication, and we're always there to help each other. So we have a tight-knit ophthalmology community, and we're doing things that we feel are special in their own right. And if you can help the people in your community, I would say go for it.
Cool. So, I think that's a great segue into my next question here. So, you said that there's a community, you guys communicate, and I think that you would be a great resource. So if members of our audience want to learn more about your approach to CTAK or connect with you directly, what's the best way for them to reach out to you?
Yeah, they can text or call me or email me. I think this is an amazing way to help patients. And the sooner all of our community across the country incorporate CTAK, we're going to keep patients from debilitated situations where they can't drive or work. So the earlier we get there, we're going to have less full thickness transplants. That's the goal. So I'm happy to help encourage those to get started on the sooner end, because those initial cases will give them wings just like it gave me.
So we'll go ahead and put your information on the episode, but why don't you go and just quickly here, as we're wrapping things up, why don't you just give them your most direct email?
Yeah, it's my first name, Sheel, SHEEL 13 at gmail.com, Sheel13 @gmail.com. Feel free to touch base, and I'm happy to help out.
Well, Dr. Patel, thank you for sharing your expertise, your experience, and your insights into a procedure that's truly shaping the next chapter of corneal surgery. Your passion for improving vision and quality of life, not just for your patients, but for your entire community. It's inspiring. It's been an honor having you on the Q-Switch Conversations. We appreciate the time, the knowledge, and the energy you brought to today's discussion. And to our listeners, stay tuned for more conversations to keep you on the cutting edge of ophthalmology. Dr. Patel, thanks for being with us. It's been great.
Thank you very much, Spence, for having me. What you're doing is fantastic. We're all getting connected by what you're doing, and I'm looking forward to hearing more of your podcasts going forward and some of your previous ones. So thank you, and keep rocking it.
Thanks, man. Well, the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that shaped my career and my perspective and my passion for what we do. This platform is truly built for you, the clinicians, the innovators, and change makers, redefining what's possible in our field. So if you have got a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on the show. You can hit me up on LinkedIn or drop me a note at d.spence@meridian.ch. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, this is Spence, and I am out.
You're listening to The Q-Switch with your host, Spence.